for me, I'm very much, I'm here's a problem. Let's take care of it. I have a solution for that.
Our goal when we opened was to provide the highest quality care that was possible at a price people could afford.
I literally talk to physicians daily. Kelly, I can't even log in to see my own billing. I have no idea what's going on. I get a report once a month and nobody can explain it to me. I make it a point to train the physicians how to go and pull their own report.
I'm going to be on the course reporting tomorrow afternoon.
You are?
I am. I'm going to follow Jordan Spieth and Will Zalatoris and Scotty Scheffler. I'm not really reporting, but I am going to go watch the part.
Probably drink a couple beers.
Yeah, I might have a beer or two tomorrow afternoon. I mean, that would make my commentary even better.
Hey, everybody. Welcome to the Cutting Edge Podcast. Today is episode 12. Very excited to have our conversation today about the role of independent physicians in containing healthcare costs and really the future of healthcare. My name's CJ Brock. I'm one of the hosts. Tyler Tallman, who is normally my co-host, is not here this week. He's actually hanging out in coastal North Carolina with his family on vacation. So shout out to Tyler. Thanks for hanging me out to dry. But we'll shortly get to our topic. But before we go there, wanted to go ahead and make a few mentions for folks that help support our show. TexAssist, Surgical Assist Staffing. Thanks to them. That happens to be my company. But great support from them. Also from the Carrington Group, which is a family office, specialty family office here in Dallas. Also Moonshot Marketing Group. So without Jen Eaton, Jen, got to say thank you to you. Without you, we couldn't do what we're working to do, which is disseminate all this great information out to the community. You can find Jen at moonshotmg.com. She's helped us with websites, social media, really been a great asset for us. And Ortho Lone Star has been a faithful supporter to this point. Really appreciate Rick Weimer and the group there. We actually had the Carroll Clinic on last week for a 100-year anniversary show. It was, man, what a trip back in time. So without further ado, you can also find us on multiple social media platforms. You can find us on LinkedIn. You can find us on Facebook. You can find us on Instagram. You can also find us on YouTube. So we have a YouTube channel, the Cutting Edge Podcast. You can also subscribe to our channels on Spotify, as well as Apple Podcasts. So lots of ways to find us, lots of ways to find our information. Would love for everybody to share what they're going to hear today, because I think it's going to be an episode that goes by pretty darn quickly, and some great guests. So with that, we're going to go ahead and get started, guys. So with today's topic being independent physicians and their role in containing costs in healthcare, got some really well thought of people in our community to join us today. And we'll start with introductions here. Directly to my right is Scott Flannery, the CEO for North Texas and Oklahoma for UnitedHealthCare. I got to tell you, I was a little bit nervous knowing that you were going to be coming on the show, and never met anybody of your stature.
The titles are way more impressive than you think. So.
But hey, thanks for being here. I'd love having the opportunity to have a payer present to be able to share their side of the field, because we just never really get that opportunity. So across the way here, sitting on the inside corner of the track is Dr. Rick Snyder. Dr. Snyder, you are with HeartPlace, correct? Spent a great career in cardiology here in DFW. And what is your role with Aspen Physicians Network?
So with Aspen Physician Networks, I'm the chairman of the board of Aspen. Okay. And Aspen is a multi-specialty independent network of some of the larger independent specialty groups in Dallas-Fort Worth marketplace.
Awesome. And then on the outside corner is Danny Conaway. Danny, I want to make sure I get your title right. Is it director? Is it CEO? Is it wearer of all hats?
Person of all things. I do it all at Aspen.
Awesome. Well, again, can't thank you guys enough. I think where we want to get started, and we'll jump right in here, is just to get a little bit of background on everybody. And we'll reverse course here. Danny, we'll start with you. So kind of share your current position and what you do with Aspen, but also a little bit more about your background and what's brought you to where we are today.
I've been in healthcare about 30 years. That's therefore all the gray hair here. Been with Aspen now for, I think, 3 years now. And having a lot of fun with it, very excited about it. My background is working with physicians on the physician side of healthcare. The whole career I've been on the physician side and very adamant about supporting the physicians. I think this position to me, it was very personal in that through some health challenges of my own, I wanted to be in a role where I could make a difference in healthcare. And the group at Aspen is a group of doctors that are very serious about improving the quality of care and lowering the cost. And so for me, it was a good fit to work with this group.
How many physicians are members of Aspen?
We have 17 different groups representing 14 specialties and just under 500 physicians.
Wow.
All specialists.
Incredible.
Yeah.
That's a heck of a mix. So lots of opinions to manage, I'm sure.
That's correct.
So Dr. Snyder, jumping over to you, share a little bit about your professional background. Obviously a cardiologist, but kind of take us back to how it all started.
Well, kind of my day job, I'm board certified in general cardiology, interventional cardiology, and heart failure transplant. Dallas guy, I've been practicing here in private practice in 1993. And one of the things that I noticed as I was practicing is that it's not so much about the science, about who gets access to good care. It's sometimes the regulation, it's the reimbursement environment, it's the legislative environment. So kind of early on, I saw the impact of, if I'm going to be a true advocate for our patients, I want to be involved in the legislative aspect. So I spent a lot of time in DC, Bethesda, Austin. Another one of my titles currently, I'm chairman of the board for the Texas Medical Association. So we work on it from that aspect. But on the private practice side, we want to create a model where we can have higher quality and lower cost. How do we optimize that quality cost curve? Because there's different aspects you can bring to that. So this is why we got involved with Aspen, because we were looking around and we were seeing with the market, with the large hospital systems, a lot of the physicians are aligned with hospital systems. But we think independent physicians are uniquely situated and have an edge in terms of really optimizing quality and lowering that cost curve. Interesting.
So we talked previously to the episode starting. You're an alumni of Notre Dame. Do you have your Fighting Irish pose ready to show everybody?
Well, I got my number one, and yeah, I got as we were talking earlier, every one of my offices in my clinic has a Notre Dame poster or whatnot in there. So every one of my patients will ask me this season, well, how's Notre Dame doing?
That's awesome. Well, great to have you on the show. I'm looking forward to some more information from you. So we'll finish up with you, Scott, in terms of a little bit of background. So, you must hear, it's funny in my head, he said, higher quality, lower cost. I went, Bueller, lower cost, Bueller. Is that the part that resonates with you, or is it the quality part that resonates with you? And I guess maybe before we jump into that, just share a little bit about how you've gotten to where you are today.
Yep. So I moved to Dallas in 97. I started working for UnitedHealthCare in 99. So I'll actually celebrate my 22nd anniversary with UnitedHealthCare next week. So I started in the sales side and worked my way up through kind of general management positions, sales leadership positions. And as we were talking about earlier, this is my second stint as the health plan CEO. And what that really means is I have responsibility for not only dealing with our network provider partners in the marketplace, but also with our customers, and then pretty much anything else that comes along during the course of the day. I hear pretty often from legislators and folks that may not like the way things are going and things of that nature. But all in all, it's just a general management role of our businesses here in North Texas, and then I have responsibility for Oklahoma.
Gotcha. So how big is your business here in North Texas?
We have about 850,000 members that we're responsible for here in the North Texas marketplace. We've got another 300,000 up in Oklahoma. So that's how big our footprint here is. We're obviously contracted with all the large hospital systems, pretty much all of the providers, both independent and hospital owned. So we've got a pretty big footprint here in North Texas.
Awesome. Well, I don't know that I want your job, but I think maybe I want your stock options plan for 22 years.
Yeah, the two come together. You got to take both of them.
Yeah, there you go. Well, so we're going to lead off with a killer question. I'm going to let you guys kind of decide who wants to take this. But for our audience, what are the core cost drivers in healthcare today?
Well, you're the payer. I think you understand the cost side more.
I think at the end of the day, there's a general philosophy out there that the whole system operates on a bell curve, right? And you can really look at the left side and the right side of the bell curve being low cost and low efficiency, and high cost and low efficiency. And if you could kind of narrow yourself down to the center of that, you can really drive a lot of excess cost out of the healthcare system. And so when you think of low quality, low cost, there's a lot of providers in general out there that aren't doing such a great job, and they're inexpensive, but that doesn't really matter because they're leading to more cost in the system, right? And then there's ones out there who aren't very high quality, who are expensive. We won't name any names, but those aren't helping the system either, right? And so I think this general philosophy around higher quality, lower cost, what a lot of people hear is, I've got to take a rate cut, and that's not what it's about, right? What it's really about is how do we gravitate the population to the center of the bell curve to make sure we're getting the highest quality and the lowest cost. And cost isn't what you get paid today, but what is the overall episodic cost? So from the time that patient walks into the door till the time they're completely recovered, that's the cost, right? It has nothing to do with what you're reimbursing an individual physician for an individual procedure. It's that overall continuum of care that really is what cost should be measured on. And so I think that's one place, and I don't want to put words in Dr. Snyder's mouth, but that's one place where we are becoming aligned. I think we all agree that that's what it should look like. Now we've got to come up with the methodology and the reimbursement methodology that makes sense for both sides, knowing that, as we talked about earlier, 75 cents of every dollar that we pay out to the provider community is not our money, right? It's a self-funded customer who's entrusting us to manage their benefits. But I think the one good thing I would say is all those things are headwinds. The tailwind is that the provider community and the payer community is becoming very much aligned in what those things should look like.
Very interesting. In preparation for this, we exchanged some emails and exchanged some ideas about some areas of focus to be able to manage more efficiently. And it's one thing for UnitedHealthCare to say, hey, we're gonna mandate this. It's another thing for the physicians to step in and say, we want to participate and we actually think we can improve the result. So maybe talk about what those areas are that are really driving healthcare costs and where the effort is being focused to rein things in.
Well, I think if you look around, just physician groups are uniting for scale. You see that with independent groups, you see that with employed groups. A lot of them are doing for a reason which I think they're missing the mark. They're doing it for leverage. And if they're only doing it for that, they're really missing the mark. They should be doing it for two very important reasons. Number one, data, but also creating efficiencies in terms of collaboration and co-management of those patients. Because in the future, especially in the emerging value-based reimbursement environment that we are seeing, data is going to be the new currency. The mining, collecting, analyzing, and selling of data is the future of medicine. And it's much easier to mine, collect, and analyze that data if the organization, if you really encompass the entire, or as much as possible, continuum of care. And then for our model, especially what we see in Aspen, that would be in a multi-specialty model. Because if you can have all that data, we can learn from that, and then we can use that data to change on how we behave in terms of choosing the low-cost sites of service, in terms of how we co-manage with different specialists. Because what I do with heart failure, very rarely is it just one specialist taking care of them. Quite frequently, you have a pulmonologist, you have a nephrologist. And so we've actually created care pathways within Aspen. When we have a heart failure patient, when do we bring a nephrologist in? When do we bring in the pulmonologist? Because right now the model is primary care physician sends me a patient, they have heart failure. And I do an evaluation, and sometimes I determine it's not heart failure. And I said, maybe we need to send them, maybe it's the lung. Maybe you send it to a pulmonologist. I send it back to the PCP or primary care physician, then they get a pulmonologist. In our model, we cover all of that. We want to be the easy button, the multi-specialty solution for not only a primary care physician, but for the payers and the systems as a whole. We think that's going to be a much more efficient model. By us having that data, that entire continuum, that'll give us some insight on how we can be more efficient with our co-management within our group, but also choosing perhaps the high quality, low cost sites of service that would benefit us. And this is why we think as an independent organization, we benefit. because one of the problems with, I use the word employed or aligned physicians, they're tethered, they're shackled to one hospital or one hospital system. Probably one of the most important weapons in terms of lowering the cost of care, especially in a value-based reimbursement model, is choosing the lowest site of service. As we like to say in Aspen, we're hospital agnostic. We want to be able to have at our disposal all the different sites of service and use that data to find where's the highest quality, low cost, and be able to offer that to our patients.
Interesting. There's a couple things that come to mind. One for me is, how do the primary care docs feel about this, where you're taking some control away from them, or it feels like, it sounds to me, from the outside looking in, that you're taking some control from them, versus what's the reality of that?
Well, I've had some payers tell me one not Scott, but it was like it said that it was 90% of the potential cost savings in a value-based reimbursement model is choosing the site of service. Now, I think it's important. I don't think it's 90%, but we've all here, and you could probably expound more in detail about this. There's an incredible variation of the cost of a catheterization or knee replacement, even the Dallas-Fort Worth Metroplex. The problem is, a lot of us don't have that data. A lot of the physicians don't have. They're tethered to one system. They don't have the ability to take those patients to lower cost sites of service. So when you choose that site of service, who's choosing the site of service? Most frequently, it's the specialist. And the way primary care is working now, not only primary care physicians routinely don't go to hospitals anymore, that's hospitalists. You have a different primary care physician in the hospital taking care of those patients. They don't choose the site of service. So really, you want to empower those who are actually choosing the site of service for an elective procedure, a hip, a knee. You want that to be the specialist, but you also want them to have the opportunity to have available to them different hospital systems, not just one.
It's pretty interesting. So, Scott, as you listen to Dr. Snyder's response to that question, what are your thoughts about, employed versus independent? Because I think I read an article, maybe through Becker's Healthcare, in the past couple of weeks, where they said the employed model now has as much as 70% of physicians in the United States are employed or tethered, as you spoke. What's your thought there?
Well, I would say in all fairness, both models are evolving, right? And there's a lot of activity, a lot of action going around the value-based. I would like to address though the primary care, at least in my experience, the independent primary care physicians, they welcome the model that Aspen brings, and here's why: because part of their value-based contract is where they're referring business. And so when they're referring to the highest quality and the lowest cost specialty group or specialty groups, they actually have an opportunity to gain in their value-based contract because they're using, the specialist they're using is using the right side of service, and they're not having complication rates, they're not having reinfection rates. So that actually impacts their overall income from a value-based standpoint. So I guess my point of this is, if you can do these things the right way with the right partners, you can align folks' incentives where nobody feels like they're getting their toes stepped on. Everybody's practicing at the top of their license, right? And you're not bringing, Dr. Snyder doesn't want to see an inappropriate referral, right? Because that's a waste of his time, and he probably missed another patient. We can help primary care physicians to make sure that that's how it's working, right? That they're only sending things that need to be referred there. And so I think there's an alignment there. I don't believe that most rational thinking primary care physicians see this as a threat. I think they see it as an improvement.
And if I can just dovetail on what you said, that's a great setup. What we actually did with Aspen, we actually worked with the Genesis primary care physicians. And what Genesis charged us to do is create a series of mini webinars, 15, 20 minutes, about chest pain, asthma, shortness of breath, when it's time to send it to us, when it's too soon, when it's too late. Because we certainly don't want to get a referral that's too late. We don't want to lose that opportunity to intervene and lower the cost of care. So we actually created this for Genesis. They have it at their disposal. We actually performed these live and taped them. And for physicians that weren't able to see those, they can go back and see those. And I think Genesis gives them some points, if they review those about, when's the right time to send to the cardiologist, the nephrologist, the ortho doctor. What are some things to treat, to try if you got low back pain? Sure. So this is what we want to work, in our relationship with the primary care physicians. He's absolutely right. Independent PCPs, they need an independent specialty network, because if all the specialists are all aligned with a hospital system, that limits their ability to work with the lower cost of care.
Sure. So, Danny, one of the things that that comes to mind is, you spoke of Aspen being made up of specialist groups. Is there a future in having a formal alignment or a formal introduction of primary care groups into Aspen, or is it more of an affiliation or an affiliates type program with what you guys are seeking to do?
Yeah, being a specialty organization, it's still important to emphasize that the primary care is important. But as specialists, I think our role is really to align with all the primary care groups out there, not just one, and bridge that care to all of these groups, especially the independent primary care. One thing I'd add to what these guys are saying, and I think the model that's really evolving is more patient-centric and doing what's right for the patient. And a lot of that is streamlining this whole process for them, because right now the patients are confused. And when you have them in a confused state, then they don't show up for that visit. They don't know really the value there. What are they going to get out of it? And in a more patient-centric model, I think they're getting the care then they need when they need it.
Very interesting. You know what? Again, going back to kind of our preparation for today, there was mention of managing inappropriate utilization of certain aspects of the healthcare delivery continuum. So we've talked about site of service. What are some of those other areas where you feel like the two of your groups, between the payer and Aspen, can work together to better manage?
Well, I'll throw out one. One is very simple: plan design. Right? If you think about where we've evolved in the plan design of healthcare, we've created deductibles and co-insurance and out-of-pocket maxes to try to curb behavior, and it hasn't really worked, right? So if you think, going back to Danny's comments, if you think about getting patients the right treatment at the right time, you can actually build benefit programs that, number one, incent the members to stay inside of a primary care physician group that's working with Aspen. So you're kind of, again, narrowing that bell curve down to the highest quality providers. Then you can do away with things like high deductibles and co-insurance, because those things were created in order to try to curve where folks go. You don't need to curve it if you're going to the highest quality, lowest cost places, right? And so one thing I would throw out is just plan design, right? If you align with a primary care physician group that's referring to the most optimal specialty group and using the most optimal sites of service, do you really need high deductibles, right? And so those are the things you can think about as kind of how to redirect patients.
So does that start with educating the consumer, or does that start with educating the employer, given that the employer makes up 75% of your premium base?
In the commercial market, it starts with the employer. In the other markets, Medicare, Medicaid, in exchange market, it's going to have to go direct to the consumer. I think probably the biggest headwind that's letting that not happen today is the idea that I've got to have everybody in my network in order to offer this to my employees. And I think employers are coming to the realization that maybe that's not true, or maybe I'll fund to the most optimal plan. And if you want everybody, then you're going to have to buy up as an employee to those, because what we do know, and I think we could all agree, is that if we could again keep it in the center of the bell curve to the lowest cost, highest quality providers, we can make a big difference. And that doesn't mean that providers take less reimbursement, right? That means
that's critical, right?
Yeah.
Because I've heard the term narrow network be thrown around in healthcare for years, right? I mean, I'd almost venture to say 7 to 10 years.
Right.
And that's a scary term for a consumer. For me, as somebody who's not a physician or an administrator in a physician's group. So how do you rebrand?
Yeah.
How do you rename
we don't
that?
use that word.
Yeah.
What we use is high performance, and that's what it is. Because at the end of the day, there are some of our competitors that they've chosen to build their narrow networks by whichever providers are willing to take a 20%. I'm making that number up. 20%
Sure.
lower discount. That doesn't make sense. I don't want a low quality provider, and I will say it on this show. There are low quality. There's low quality in everything, right? So low quality providers taking a 20% discount doesn't do anything for the long-term cost containment for an employer, right? You're just having somebody who actually has to take a lower discount in order to get more patient base, and funneling patients to them, and they may be of low quality. So what we believe is it makes more sense to focus on, start with those that are already high quality and say, okay, let's work out a financial arrangement that works for you, that works for the employer, and that makes sense moving forward. And that's how we're going about it. So I agree with you. Narrow network, that term is a kind of a bad connotation to it, and we actually don't use that externally.
Interesting. So is this, as this conversation opens up, what I'm gathering as just the average Joe sitting here on the outside looking in is that this is kind of what value-based care means. Is this really at its crux the essence of value-based care?
Yeah, I think so. The key to value-based care is avoiding the adverse events, and you do that through quality care. As we keep talking quality, I'm always very careful when I'm talking to my physician members to lead with quality rather than lower the cost, because you're right, when you say lower cost, that most physicians say, "Are you going to ask me to take less money?" No, we're going to squeeze out the excess by providing a higher quality and getting the right care there.
And we actually have various committees within Aspen. One's called the Quality Committee. And one of their charges, amongst other things, is create our quality pathways. But I'm not going to sit here look you in the face and say all 490 some odd physicians at Aspen are A+ Dak Prescott level performing physicians. Right. We have a curve, we have a spectrum. Overall, as an organization, we perform very well, but there are some who are not performing as well as they could. So what we want to do is use that data and to show where they are not meeting expectations in terms of a quality aspect or a cost aspect, and try to coach them up. But we've even decided that there may come a time where there are some physicians, despite our best efforts to coach up, they are still not meeting the standard that we want to provide our patients and the payers, and that they may have to be excluded from a contract.
It's interesting. It sounds like there's an opportunity for this organization and the relationship between the payer and your organization to essentially create kind of a best-in-class multi-specialty group, right? It attracts the physicians who really are top of their game because they want to come participate, because you guys have protected. If they perform, then you guys have protected their financial.
Let me tell you how we formed Aspen, how we chose what the groups.
Yeah.
The number one thing is it's chemistry. That's going to be strategy for breakfast, lunch, and dinner.
Yeah.
And it's that chemistry and that collaboration. So we didn't take a bunch of numbers, say we want this group, and D Magazine does their thing. Who would you send a family member to? It's like, who would you want to be working with in this type of organization? So we got our administrators together, and for about 6 months. So how would this look? Who do we want to be in there? But we have a motto. Check your ego at the door. Every group has one board member. If you could be a group of 90 or a group of 16. The point is we need to work collaboratively together. And when we decide that, and it's really, we have not started marketing or sending out blanket invitations to groups. Most of the time, about 9% of the time, groups hear about us, they want to join. And I'd say less than half, we decide this is not the type of group, just by working with them or whatnot. And the doctors don't need the data; they know who are the good quality groups, or by working with them in the hallways all the time. So it's about chemistry and that that collaborate. It's culture is essentially what's the most important thing.
Right. Danny, in our initial conversations, I go back 4 or 5 months when we were first introduced. You shared the term clinically integrated network. To my knowledge, this is really the first CIN. I guess the question is this the first true CIN in North Texas? Or at the very least, one of the early ones? And what's the true definition of a CIN?
As far as specialty groups, yes. There's primary care, a primary care CIN, and Scott knows them well. And Scott has worked with a rural CIN and putting that together too. So there's other forms of it. By clinically integrated network, the way we look at it is a virtual network to allow our members to act as a single clinic, even though we're separated in groups. And that's important from the standpoint of being able to deploy the technology that's needed to provide the proper care.
That's interesting. So virtual network, so really you're operating because of the similarities in how the groups think and how they perform, you guys can operate as a single unit. It's like you guys are all on the offense together, right? I mean, that's what it sounds like.
I mean, the way it works now, we call it a curbside consult. A doctor has a patient, they're not sure what to do. They happen to know me. I'm in their contact list. They'll call me up. We want to be able to do that virtually. So our IT department actually created an app. It's an Aspen app. It has every doctor by every group. It has their office number, has their GPS enabled location. So if you're at Medical City, Dallas, and you need a orthopedic physician, you can see where's the closest one to where the hospital is or the patient is, because a lot of these doctors aren't going to know each other. So we need to have familiarity with that, so you can use the doctors in the network or be able to call them up and say, hey, I got this patient. What do you think I do? Do I see you in the office, or can we try something else?
Interesting. Scott, as I listen to this, what makes you most excited about this relationship that you're building with Aspen at this point?
I think two things. One is, which Dr. Snyder touched on. We have the data, right? So, one of the things I think that's always been challenging when you think about, before clinically integrated networks is, a patient goes to see Dr. Snyder. He does what he knows is right. He practices high quality medicine, but there may be other things going on that he's not privy to, because they may be seeing, you name it, an endocrinologist that's in another practice, and so he doesn't really know what that doctor's telling him to do. So we have the ability to bring the data together and basically aggregate it and be able to share information, and I think that's important. And you mentioned it earlier. I mean, the data is really super important when it comes to that. I think the second thing is, we can work. So to answer your question, we can get to this optimal level that we've been thinking about and talking about for a long time, and go to our employer groups and saying, hey, if you really are serious about bringing down your healthcare costs, here's how you do it, right? And you get, I think Dr. Snyder's underplaying a little bit. I think the yeoman work that they did in getting like-minded folks inside of Aspen, that's huge, right? Because check your egos at the door. You got a lot of big egos. You got a lot of folks that their way's the right way, and they're not all going to work, right? You got to get like-minded people who are aligned with where the direction of that organization's going. And I think Danny and Dr. Snyder have done a good job at getting that done. And getting the like-minded people there. It's not going to happen if you have dissenters in the group, right? And quite frankly, you alluded to it, that you've got to be willing to, over time, you've got to be willing to let people walk if they're not willing to kind of get in line in the direction that everybody else is rowing. No, not unlike any sports team, right?
Sure. So, ultimately, from your perspective, Scott, what do you think? Obviously, there's going to be a clinical excellence impact here, which is going to be really measured on the physician side. But what do you think the economic impact could be for the consumer and for the employers?
It's huge, but let me step back and say, here's the good news: is as all of this kind of transpires in the marketplace, it's not about taking, and I'll just use this as a simple example. It's not about taking somebody who's practicing at a quality level today of a 4. This is just arbitrary. And moving them to a 10, and then you see this huge savings. The reality is, when the 4 moves to a 5, there's an efficiency and a savings that's associated with it. So it's really about lifting the whole group up and helping them lift up. And I think that's something that groups like Aspen and other CINs and ACOs in the marketplace are doing, right? So it's like, let's bring everybody up. What is it? The rising water raises all boats.
Right.
So that's the idea.
So all ships. That's right.
And I would say we would all agree, us included, nobody's at the ceiling today, right? We all have room to get better. And so the savings can be huge. I don't like doing commercials for my company when I'm on these sorts of things, but what I'd say is, we've built a product that's narrowed around the center of the curve, and it shows 22% savings in the marketplace. Right now,
wow.
It's about it's about a third. It's about a half of the panel that you would normally get in a PCP panel, but it's generating 20+% savings. And so those are the things you can do when you're focused on quality and lowering the cost.
So one thing I noticed, I didn't see Dr. Snyder or Danny cringe when you said 22% cost savings. So that must mean that there's something of benefit financially. There has to be some benefit to the physicians.
Well, I think he's alluding to in terms of efficiency. If you have a high-performing, efficient network, that's going to perform well. For example, a lot of us are part of this episodes of care with Medicare called BPCI, Bundle Payment Care Initiative. Probably the two most powerful ways to limit that cost is reducing readmission and choosing your post-acute care. Where are they going to go once they're out of the hospital? Are they going to go to a SNF or a skilled nursing facility, which is high cost, or a long-term acute care facility, or other types of in-hospital rehab? Those are still pretty high-cost sites of service. When I say we're all specialists, one of the groups that's part of us is hospitalists. I view a hospitalist as a specialist because quite frequently the hospitalist, when they're seeing that patient, when they're that primary care physician in the hospital that we work part of, we've got 2 hospitalist groups who are part of Aspen. They not only follow that patient in the hospital, but also to the post-acute care setting, to a SNF or an LTAC. So they are able, because one of the observations we see, because a lot of the plans have 30 days at a certain location, and magically day 29, patients get better.
Yeah.
And sometimes they don't really need to be in hospital, or a lot of them can be at home. But those physicians help direct some of the home-based healthcare, but they also help see those patients in the SNFs, in the LTACs. Sometimes they have a little bit of irregularity and the reflexes send them back to the hospital. But if they were the same doctor group that saw them in the hospital and said, "Oh, we know about this, we can still manage it there," that's a huge benefit. One of the things we always like to say is, in terms of when somebody does need a procedure, it needs to be the right patient, the right procedure, at the right place. And one of the benefits of not just an independent group, but Aspen as a whole, most of our groups have our own non-hospital locations where we practice. ASCs. Our group, we have 2 ASCs in the market. The GI doctors have ASCs, Carroll Clinic, a lot of the orthopedic. So we can offer some of even the lower sites of services than what the hospitals can. Not all those patients are the right patient, and we still want to work with our hospital colleagues, but we want to be able to bring that option to our patients, that, hey, we can save you 25 to 30% at a high quality ASC, we're getting a lot more experience, and Scott can probably talk about that. But I think that's going to save ultimately the government. You're seeing this, with the healthcare in general. How do you find the lower cost of service in either a retail, health clinic, with an Amazons and the Walmarts? Where can we really beat that cost curve? And we need to be creative about that.
Sure. So, cost savings and increased quality in those things are fantastic. But one of the questions that sits in the back of my mind is, for the physician, there's this general trend over the last, how many years, 10, 15, 20 years, that reimbursements have gone down, earnings or earning power has gone down. So what's the financial upside? What's the zinger for the physician to say, "Hey, doc, you should really embrace this"? What's the end game for the physician financially?
Well, I think if you look at cardiology, 75 to 80% of cardiologists are aligned with the hospital system, and they've actually seen their reimbursement go up, but probably for reasons that are not beneficial to the patient-physician relationship. And I don't think that's going to be a long-term solution. I think really, if we're going to really do what's right for the patient, we need to explore other ways that we have to lower, increase that quality and lower that cost. When we go to med school, it's always about the quality. We get very little exposure to what the cost implication is. We have very little data about that. You mentioned about, we've got the data. There's 2 different types of data. There's performance data, which we have and we're beginning to utilize, but there's also clinical data. Unfortunately, there's so much redundancy. Somebody said, "Oh, I just had this test done at hospital A, but now you're in the ER at hospital B, but I don't have access to that." Or this happens at least 50% of the time. I'm seeing a new patient, they don't bring their labs. I need to have that lab to be able to make a decision. And they say, "Oh, my primary care doctor, I told him to send it to you." Well, that's a big burden on a primary care physician. If they have to, be sending paper everywhere to all the different specialists, they probably have to hire 2 or 3 FTEs. And there's a liability with that, because if they're faxing it, one wrong number, as a HIPAA violation. So that's a problem. I think part of it, we're trying to empower our patients that they need to be responsible to a little bit for their medical records. And now with the new legislation, they do have access to that. All patients' medical records are available to them within supposed to be 1 or 2 days. And I tell my patients to bring that. But if we had an HIE, Health Information Exchange, that would be very powerful. And I think, because we are all independent and we are trying to have a clinically integrated network, hopefully we're going to be sharing this data and minimizing how much of this redundancy.
So what role does UnitedHealthCare play in the creation of a health information exchange, or the actual clinically integrated network itself?
So again, at risk of doing a commercial, we already have it. The problem is that if Dr. Snyder sees 10 patients in a day, only 2 of them are with UnitedHealthCare and 4 with another. I think the challenge right now is that providers are looking for a system that's carrier agnostic, and that doesn't exist today. The crazy thing is, one of the things that happened, and you and I were involved in one of those committees, right? Way back when, one of the things that came out of the ACA was this formation of the HIEs, and the federal government spent millions, if not billions of dollars on it. And I only know one that's still in existence today. And it's up in Oklahoma. So we threw a lot of bad money at a really good idea. And it never came to fruition. I think, again, this is my own personal opinion. I think a lot of those who controlled the data were squatting what the use should be of it, and not focus on what the end use of it should be, which is making seamless treatment for the patient. We're getting back to that, but again, we've got to come up with something that's carrier agnostic, so that we can't ask Dr. Snyder to go into 6 different systems in the course of the day based off the patients that he's seeing. The one thing I would say, though, about the primary care physicians and the ability to transfer records, I think one of the things we've got to think about, we're already thinking about, is we need to pay them for that, right? I mean, they're the quarterback of the care, and so if we're being asked to send referrals and to send information and not do tests over again, then we need to be able to pay them to actually send the data. Have that 1 or 2 people in the office. Hopefully that goes away and you can use technology for that. But we've got to actually pay for those things to happen, and that's already starting to happen. So you can't have this seamless network if you're not transferring data in a timely manner.
What's your employers that retain you to run their benefit plans? What do the employers have to say about all this? I mean, how savvy or how educated are they on what's going on here?
I think it varies. So just like anything else, especially during the COVID era, as you have some smaller employers. You have the benefit of HR, is also the payroll person, is also this. And so do they really get into the details of this? No, they're looking for an affordable plan that gives their employees access, and quite frankly, probably keeps people out of their office, with issues. Versus maybe some of the larger companies where they have, some of them have chief medical officers, and they have 3, 4, 5, 6 people on staff inside their benefits department. I think they're more in tune to that. So I'm not knocking one against the other, but it's just, I think, a matter of so there's some folks that we deal with that are students of the benefit game, and there's others that are doing it off the side of their desk because that's what the business calls for. But I do think at the end of the day, nobody argues higher quality and lower cost. Everybody's aligned with that. Right. I think it's just a matter of how you do it is the kind of devil in the details, right? Yeah.
So, Danny, I'm going to take a step back for a moment, and you get access to all this data and you get access to all this information, and there's coachable opportunities for the physicians. How do you, as the administrator, the lead administrator of this group, position everybody to be, maybe not necessarily position them to be open, but for the delivery of that coaching, for the access to the information? What's your role in that?
First, I'll say I'm still hung up on. I heard Scott say that But technology is rapidly developing right now, and I guess I see my role as what can I do as administrator of this group to give the tools here to allow our physicians to practice at the top of their license. And that's really the key to them improving where they're at, is how do we keep them practicing at the top of their license. HIE and these things are rapidly developing on how to get the information, but not only getting the information, but then how do I get it in a form to the physician so he has the right information at the right time. It has to be usable to them, and that's also a challenge.
Sure.
So what we actually do with the quality committee, it's a physician committee, and ultimately it's got to be the physicians driving those discussions in terms of the coaching and ultimately making a decision. Despite our efforts, we can't change behavior or get them up to a level from a quality or cost standpoint that meets the standards. The way Aspen is actually constructed, I mentioned earlier that our board is a purely physician board. We meet once a month, but we also have an administrative committee where the the CEOs from every one of the large groups meets 2 weeks before our board meeting and come up with different proposals in terms of modeling. How can we do this differently? They make recommendations to the committees, which then go to the board. And quite frequently, the administrators to come with that. But in terms of, how do we get that? Because that's a delicate situation. Here's someone who is a performing physician, but not everybody's high performing. And we don't want to exclude anyone that we think we can coach up. At the end of the day, if we can't, we all have decided we're going to have to make some tough decisions. But we're not going to be reluctant to do so.
So we've got just a short amount of time left. This conversation has just flown by. But one of the last questions that I have that I want to address is, what's the patient's role in all this? And at what point you have to look at the patient and go, you must be more accountable for your own care and for your own management of the checkbook. Thoughts?
This is one of my frustrating things. I see patients all the time who come in with a heart attack. I come in the middle of the night, put in a stent. Most of the time we can get them home in a day or two. They come back and see me for their 3-week or follow-up appointment. They haven't filled their medicines, even though they're insured, or they still have a big bulge in their breast pocket of Marlboros. At the end of the day, they got to work with us. It's like, a teacher working in class. They give the kids an assignment. They don't study or do the assignment. It's no wonder they're not going to pass the test. So there's got to be some sort of collaboration. There's got to be some give and take. Sometimes a lot of the patients will just go to the emergency room without calling us or trying to work through a problem. So I think there is opportunities for that. And I think, especially in terms of plan design, that's going to be more on the payer and the self-insured employer to really kind of work through those nuances.
Is there going to be, and this is a physician-directed question, there's non-compliant patients at every turn, but is this, I don't want to incentivize, but does this sharpen your potential to say, I'm no longer going to treat you because you've proven over and over again that you're not willing to follow the medical directives that we put out there?
We do that now. You can dismiss a patient from your practice. We're doing it more often because sometimes patients just don't show up. They haven't been to the clinic for a couple of years, but they want their medicines refilled. That's not good for them. That's unsafe, but it puts us at a disadvantage. And it's mainly in the fee-for-service model, but certainly in a value-based reimbursement model, we have to be very sensitive to that. And so do the patients and the self-insured employers. If they're not going to cooperate in their own recovery and maintenance of healthcare, that's the number one quality factor, is the patient has the biggest role to play in amongst the physician and the payer and the self-insured employee. That's got to be the focus. And it's got to begin with the physician-patient relationship.
So Scott, from your perspective, talk about accountability.
There's 3 buckets, right?
Yeah.
There's the one that Dr. Snyder, they don't care, right? And so I think that, unfortunately, that's going to be where employers are going to have to decide, do we keep these people on, or how does that move? And that's actually the toughest of the 3 categories. I think the first category is they don't understand, right? And that's where I think organizations like ours have to make it easier for them to kind of understand their benefits. And so they may not be doing the wrong thing because they want to do the wrong thing. They're doing the wrong thing because they don't understand, how the benefits work or where the optimal place to go. And then I think the middle group is there's not enough in it for me, right? So it doesn't really matter to me either way. And that's where I think the plan design can come into a huge play. Again, I promised I wouldn't do a commercial, but there's a program we're testing right now for diabetics, which basically, once you're diagnosed as being diabetic, you're invited into this group, and you get a different level of benefits, right? So as long as you stay compliant, you're getting hemoglobin A1C tests, you're using the monitor, the constant glucose monitor, you're getting the readings and all. You actually have an enhanced benefit, right? So if I'm an employer, that makes sense to me, right? If my diabetics are all in compliance and their diabetes is being managed, they're less of a overall cost for me annually, and therefore I can afford to give them slightly better benefits. They're using the tier 1 drugs. They're doing all the things that nobody argues shouldn't be done for a diabetic. It's just there's nothing in it for them to not do it. So now you make something in for it to do it. The third group, I think, though, is going to be the toughest group to convince. It's the guy who just had quadruple bypass and shows up 2 weeks later in Dr. Snyder's office and his Marlboros are still in his pocket. I don't know what you do with that guy or gal.
Yeah.
And I tell a lot of my patients is exercise and diet is the far and away the two most important things for their health. Doesn't
Right.
matter what disease you have, but especially what I do in cardiovascular medicine, I can't give them a pill better than walking 30 minutes a day and eating a reasonable diet. There is no medicine, there's no procedure I can do that has a higher benefit. And in terms of exercise, I tell my patients that's formulary for every insurance plan I know. They love the exercise. And a lot of my patients were telling me during the pandemic, well, the gym is closed and whatnot. And I said, okay, the gym is closed, but that big bright thing in the sky, it's called God's gym. It's not Gold's gym. And it's open 24/7, 365. It was never shut down. And the best part about it, every patient I know from the day they were born had a lifetime prepaid membership to God's gym.
There you go. So that's pretty good. I like that. Lifetime membership to God's gym. So
prepaid.
That's even better. So my last question for the group: what's the call to the medical community to engage and really lean in to what you guys are doing here?
I think the call from my group is, number one, it's got to start with data. We got to because data is going to help educate us and inform us on cost and quality. You go to med school, the focus is on guidelines and quality and papers, but that's only half of healthcare when you get out in the real world. You can have, the best inclusion criteria, you don't have any exclusion criteria, you're doing that quality, but if it's not paid for, you don't have access to healthcare. And one of the things I tell patients, coverage is not the same thing as access, and access to a waiting list is not the same thing as healthcare. You've got to be able to do that in a high quality, low cost environment, and not just high quality, low cost. It's got to be timely access to high quality and low cost. Troy Aikman can throw the best spiral down the field 60 yards, but if it's late and doesn't get there on time, it's intercepted. It's not that you read a good quality study, but it takes 3 weeks to get the study out to the primary care physician, you've lost. So we've got to use the data in terms of personal performance, but also have access to the clinical performance. And we've got to start embracing and understanding that we got to measure ourselves. If we cannot measure ourselves, we cannot improve. And we got to start making that part of what we do, not just seeing the patients in the office.
Gotcha. Danny, from your perspective, if you had to make a pitch to your colleagues, your fellow administrative colleagues in the medical community who manage and are steering their independent physician groups, what would be your parting thoughts for them?
As Rick was talking, what keeps going through my mind is right care at the right time, which also means, there's a lot of tools out there that patients are starting to use. And I think as providers, we have to know about those tools and reach out to employees, the patients where they're at. And some of that is when patients are using some of these online tools, are we responding to them? Even simple things like appointment request. If the patient responds online for an appointment request, are we reaching back to them, or are we just waiting on them to call us? So as administrators, I think we need to look at those tools that are available that can help us get those patients in and get them seen in a timely manner and utilize those.
Gotcha. Scott, we'll finish up with you with the big kahuna. If there's a call out to the medical community or to administrators, right, to the community at large, what's your parting thought here?
So I wouldn't even limit it to the administrators or to the providers. I would put everybody who's part of the healthcare equation in there. It's I say this all the time, so people that know me are going to laugh. But if we don't figure it out, somebody else will, and we probably won't like it, right? And so that means we have to have different conversations than we've had before. We've got to get the cats and the dogs and sitting on separate sides of the table. We've got to come to the same side of the table and figure out something. Now again, we all have our businesses to run, so we've got to figure out something that makes sense for our business, but makes sense for the consumers, that drives down the total cost of healthcare, improves the quality, because Washington will try to figure it out for us, and none of us will like it. So that shouldn't be the reason we do it, but unfortunately, that's kind of where we are today. I say that it's unfair. A lot of this work was happening 4, 5, 6 years ago, 7 years ago, but I think it's even more important now that it gets done. It's always been important, but I think the pressure just keeps getting turned up on it. We've got to have different conversations. We've got to be willing to use Dr. Snyders, and we get to check her egos at the door and know that we're going to have different conversations. And what you're doing today, what I'm doing today, we're not going to be doing that in a year from now. And 2 years from now, we're definitely not going to do it. So it's going to continually evolve. So if you're only comfortable in the status quo, you're probably not going to be in this business, going into 2025.
Or you just might be down the road at the specialty hospital for help for mental patients, right? I mean, that's sad but true. So, guys, I can't thank you enough for joining our podcast today. This has been a fantastic conversation, and can't wait to get this out to the community because I think there's so much intelligence and information to share. I mean, the collective horsepower amongst the three of you makes me feel pretty puny, but really enjoyed having you. For our audience, thanks for joining in. You can find us on Spotify, find us on Apple Podcasts. Definitely subscribe to our YouTube channel because we'd love for you to be able to see our beautiful faces and not just hear our voices. And until next week, when we run episode 13 back to everybody, appreciate you for joining, and we'll be back with you soon.